We are incredibly happy to have Dr. Duiverman with us here today, who will share her knowledge and experience on setting up NIV remotely. Dr. Duiverman is a pulmonologist at the University Medical Center in Groningen in the Netherlands. She's one of the medical doctors of the Home Mechanical Ventilation Center at that same hospital. And next to her clinical work, she teaches at the universities of Groningen and Twente. Her main research interest involves severe COPD, respiratory failure, and home mechanical ventilation, with a special interest in remote monitoring and care to facilitate complex care at home. Next to all that, Dr. Duiverman is also chair of the Group 2.2 non-invasive ventilatory support of the ERS Assembly 2 respiratory intensive care. So very welcome, Marieke. I will hand it over to you for your presentation. Yes, we see your screen and we can hear you loud and clear.
Perfect, thank you. Thanks, Breas, for inviting me today to talk about starting up NIV at home. As Carl already said, I'm Marieke Duiverman. I'm working at the hospital you see here in the bottom. And today I will share some experiences and share some research we did on this topic. I have some conflicts of interest. So I would like to start with a case today to make it a little bit more lively for you all. This is a Mr. D of 67 years old, and he's known with severe COPD, as you can see over here in his lung function, with an FEV1 of 0.5 liters, and also a severe degree of hyperinflation with an RV-TLC ratio of 71%. So this is a challenge for us when we want to start him on NIV. This is his ABG, showing that he has a complete respiratory failure with an hypercapnia of 6.8 kPa and also a severe hypoxemia of 6.8 kPa. So we decided to start him on NIV, and we decided to start NIV at home. Why did we decide that, and how did we do this? And finally, I would like to discuss with you what to take care for. So why did we decide to start him at home? What we see in the Netherlands is that there's an enormous growth in the amount of people that need home mechanical ventilation. Here you can see the numbers in the Netherlands from 1991 to 2020 and the different underlying diagnoses that we treat. So what you can see over here is that there's an enormous growth, about 7 to 10% per year. And we also see that the patients with lung diseases is an increasing group. In the Netherlands, neuromuscular diseases are still the biggest group, but we see that mainly patients with obesity and patients with COPD is a rising group. So this is a reason for us to think about initiation of non-invasive ventilation. In the Netherlands, we were used to set up NIV in the hospital. When I started in the field, we set up NIV in the ICU, and after a couple of years, we realized that that was probably not necessary, and we moved to the pulmonary ward. However, we also saw that the pulmonary ward is also overcrowded, and that became especially evident during the COVID pandemic, when we actually had no beds for our people to set NIV up. So we were questioning ourselves, is it also feasible to start NIV at home? And then, of course, we wanted to have the same end result, and it should be safe. So this is the first study we did on this topic. This is a study by Anne Hazenberg. She's a very good colleague of mine and a specialized respiratory nurse at our center. And years ago, she already set up this study. And actually, that was a question of patients of her saying, why should we move to the hospital to start NIV? Can that be done at home? So Anne designed a setup with which she started up patients at home using telemonitoring. And this was a group of patients mainly with neuromuscular diseases and some patients with restrictive thoracic diseases. Patients were randomized between the standard care, so setting up NIV in the hospital, and setting up NIV at home. And what you see here is the end result regarding gas exchange after 6 months follow-up. And you can see here that both in the home group and the hospital group, CO2 went down to an equal amount. And also the difference in change was, of course, not significantly different between the groups. Looking at the pressures and the ventilatory settings used in this study, you can see that a moderate inspiratory pressure of around 15 centimeters of water was used, with a frequency also around 15. And this is typically a setup for patients with neuromuscular diseases. But there was again no difference between the home and hospital group. In patients with neuromuscular and thoracic restrictive diseases, this was repeated in a multi-center trial throughout the Netherlands by my colleague Ries van der Bigelaar from Rotterdam. And actually it did the same as Anda did, but now the study was multi-center and all the home mechanical ventilation centers in the Netherlands participated. Again, he showed that the change in gas exchange was not significantly different between the home and the hospital group. So also when you set up this in all the home mechanical ventilation centers in the Netherlands, this works. As Carl already mentioned, my specialty is the COPD population. And the COPD population is a bit difficult, and a lot of people said to me, you showed that home initiation is feasible, but in COPD this will not work because people need high-intensity non-invasive ventilation. This is one older study by Michael Dreyer actually showing that only with high inspiratory pressure you are able to lower CO2 in patients with COPD. So from that point on, a lot of people started to ventilate patients with COPD with higher inspiratory pressures and maybe also a higher backup breathing frequency. In this study by Michael Dreyer, really high pressures were used with a mean inspiratory pressure of almost 30 and also a very high backup breathing frequency. So because of that, I said, okay, then we need to test this, whether this also works in patients with COPD, and I set up the Reconsider trial, investigating whether home initiation of chronic non-invasive ventilation would also be feasible in COPD patients. So our hypothesis was that home initiation of NIV with the use of telemedicine in stable hypercapnic COPD is non-inferior to in-hospital NIV initiation, and we defined a difference in favor of the hospital group of smaller than 0.4 kPa as non-inferior. So what did we do for the study? Actually, for all our studies, patients were randomized between the standard care in-hospital initiation of NIV, and that meant in our situation that patients were admitted to the hospital and stayed at the pulmonary ward around 5 to 7 days to get used to the ventilator and to titrate ventilatory settings. And this was compared with at-home initiation of NIV, and this is actually a real picture of a patient that participated in the trial and one of our nurses that explains all the devices to the patient. And here you see that there's a ventilator and there's also a transcutaneous monitor at home. Patients were initiated on NIV and they came to the outpatient clinic for analysis of outcomes after 3 and 6 months. We did an ABG lung function 6-minute walking test and an analysis of quality of life. And how did we set up NIV at home? You already saw in the picture of the patient that there was a ventilator sending the data to an online platform, and we also used transcutaneous monitoring. And at that time, it was not possible to send data from the transcutaneous monitor directly via a cloud or a platform to the hospital. So we needed to use an in-between device, which enabled us to send the data to the hospital. What happened in the trial? Eventually 67 patients were randomized into equal groups, 33 and 34 patients. We had some dropouts, as would be expected in the severe group of COPD patients, and eventually 23 and 26 patients were analyzed for the primary endpoint, which was change in CO2. These were the baseline characteristics of our patients, and you see that this is quite an usual COPD group of 63 years old. In the Netherlands nowadays, most patients are women. That's not in every country, but in the Netherlands it is. You see that most patients were using long-term oxygen therapy also. And you also see here that the BMI was around 25. We didn't exclude patients with concomitant sleep apnea, but we tested all, and actually there were only 1 and 2 patients who had an AHI above 15. So this was absolutely not a majority of our group. It were really severe COPD patients. Patients were unable to do also a rehab program, as we think combining NIV and rehab is very effective, and this was the case in around 20% of the participants. Looking at the primary outcome, which was daytime CO2 measured without ventilator, without oxygen, so at room air, you can see that there was a decrease in CO2 in both groups, and the difference in change was not significantly different between the groups. It was only 0.04 kPa, and also the 95% confidence interval was within the limits we set of 0.4 kPa. So this means that with regards to change in CO2 at daytime, initiation at home was non-inferior to initiation in the hospital. Looking at other outcome parameters like lung function and exercise tolerance, we also didn't see a difference in change between the groups. We also looked at quality of life, and we used the CCQ, which is a COPD questionnaire, and we also used the SRI, which is a questionnaire designed for patients with hypoventilation. And you can see that both groups improved in quality of life. CCQ is the lower the better, the SRI is the higher the better, and there was no difference between the hospital and home group. Looking at ventilatory settings, we saw that there was no difference between the groups, but what we saw is that in the group that was initiated at home, we tend to increase the pressures a bit over time, and the pressures were also a bit lower compared to the hospital group. And despite this, there was no difference in changing gas exchange. And then we also looked at the costs, and the problem is that in the Netherlands, for the standard care, we take patients in the hospital, and when you do that for a week, you have a lot of ward days, and this, of course, has high costs. So in our situation, we saw that initiation at home was far cheaper compared to the situation initiating patients in the hospital. What we did saw is that the travel time of the respiratory nurses was higher in the home-initiated group. And that was because when we initiated patients at home, the nurses drove to the homes of the patients on the first day to explain everything, and on the last day to take the transcutaneous monitor back to the hospital again. And also when the patient had a problem in between with his mask or he couldn't handle the ventilator, the nurse drove to the patient's home again. So the median number of home visits per patient was around 3. Meaning day 1, the last day, and also one time in between. And when a patient is living around 100 or 200 kilometers from our center, that of course takes a lot of time. So our question was, is home initiation of NIV effective and feasible in COPD? And I think it was. It was the first study showing that indeed home initiation of chronic NIV and also in COPD with the use of telemedicine was non-inferior to in-hospital initiation. It was safe, we actually had no adverse events, and reduced costs by over 50%. And this had important implications for both our patients and the healthcare system. So how do we do that? Now that we had 3 studies showing that it's at least feasible and non-inferior, we are of course trying to implement this strategy in regular care. So what happened with our patient? I will take you through the case further. He was visited at home and he started NIV, and then we start with daytime acclimatization. The mask was fitted and he was given education by the specialized nurse. The NIV ventilator and the transcutaneous monitor was installed, and the nurse told him to use it during the night. And then she went back to the hospital, and the next time She made a telephone call to the patient, asking him how he was doing. So this was our setup. And then we had the readouts from the ventilator. And actually what the nurse was doing on the first day was especially checking, is the patient using his ventilator? I think that's one of the most important things, of course. And what you see here in the use graphs is that there is, of course, use, and it's quite good use, but it's fragmented. So he doesn't really succeed in using the ventilator the whole day already. But that's no problem. It's a patient in an elective situation. He has no acute exacerbation, so you can take time. So what do we take care for when we set up a ventilator? This is a very nice graph from the SomnoNIV group, and I really like it when you want to make steps how to set a ventilator. And this is also very usable for us when we set a patient up on NIV at home, because we have ventilator data, of course. So the first step is, like I said already, is the patient using his ventilator? If he's not using his ventilator, it doesn't make sense to look at all kinds of sophisticated things like asynchronies or obstructions. First, check whether the patient can use his ventilator. I once had a patient who was on NIV, and we started in NIV successfully. He went home, and then after 3 months, he came to the outpatient clinic and he said, I couldn't find the switch on button, so I didn't use the ventilator. So that's a pity, of course. And when the patient is using his ventilator, we'll check for leaks. Leaks are an important problem in non-invasive ventilation. You always have leaks, and that's not a big problem. It's if it's a minor leak, but if it's a major leak, it will be uncomfortable and the ventilation will be not effective. And then you check for obstructions. You can easily check for obstructions in your ventilator curves. And if that's all okay, you check for asynchronies. So that's the same what we do when we set up a patient at home. You can check the ventilator data. So the first and the second step. And this was also a graph from Jesus Gonzalez in which he nicely showed that you have normal good ventilation. It looks very regular. You have leaks when the flow goes down. You have obstructive events, and you can have asynchronies. So then the question is, we use transcutaneous monitoring. Is that still necessary when you set up patients at home? And the first thing to realize is that transcutaneous monitoring is not easy. The nurse that participated in the home setup trial, Gerry Bladder, she looked for an ERS congress to the amount of measurements that succeeded and the problems that she encountered with transcutaneous monitoring in the trial. And for the trial, what we did, we installed the transcutaneous monitor at home. We did a baseline measurement to have some sort of baseline CO2. And we did a transcutaneous measurement once the patient was able to sleep with his ventilator. So we didn't do a measurement every night. But even if you take that strategy, so only do the measurements when the patient is able to sleep with his ventilator, we saw a lot of problem. 90 measurements were analyzed, and of those 73 were telemonitored, so the data were sent to the in-between device. And of that 73, 31 were problematic measurements. No graphs, no Wi-Fi connection. Patient forgot to connect the device to the in-between device. And also there were problems with the CO2 measurement. So for that, the nurse needed to drive home additionally in 8 patients. She tried again with the telemonitoring device, but in a lot of cases she also accepted and said, okay, the ventilator curves look nice, patient is doing fine, we'll see at the outpatient clinic how he's doing. So it's not always successful. It's nice when you can see that you correct hypoventilation, but it's difficult measurement. We still think that transcutaneous monitoring is important, as especially in the COPD population, you only see clinically relevant effects on quality of life when you really reduce CO2. And when you only look at ventilator curves and you don't check for gas exchange, I think you're not being complete. So what happened to our patient on day 2? The nurse read out the ventilator curves, and she especially looked at adherence, and the patient had used this ventilator for 2 times for 1 hour. And he said, the first night was very stressful. They had problems finding the on button of the ventilator, and the mask did not fit well. But it's the first night, so don't panic. That's not really a problem. The patient had to get used to the ventilator. And then after 3 nights, he starts to sleep with the ventilator, and the ventilator settings are adjusted according to the readouts. And the nurse calls every day to the patient. So after 3 nights, he's doing fine. And after 7 nights, she says, okay, you're sleeping fine with it. We're going to do a transcutaneous measurement. During the weekends, the nurse is not calling the patient, so we only do that at working days. And we really think that's not a big problem. You can give the patient some time to get used to the ventilator. And then on day 8, the transcutaneous measurement did not succeed, the data were not transferred, and she drives home to the patient's home again, measures during the day, and re-explains the measurement. And on day 9, the transcutaneous measurement was repeated, and it looks very good with a CO2 below 6 and a saturation of 91%. He slept well. The nurse goes to the patients to return the transcutaneous monitor and end the initiation period. And Mr. D and his wife were very satisfied. And a lot of patients are telling us that they are very satisfied that this happened in their own environment. It's more quiet and they feel more relaxed. And when patients have more caregivers, you can also explain the ventilation and everything that has to do with the ventilation to the caregivers more easily. So, what is necessary to make this a good solution? Home initiation with telemonitoring. I would like to raise some questions regarding that issue. So is this a reasonable option for all patients? Patients and caregivers should be digitally proficient, and that might be a problem. Some people really have problems using digital devices. Quality should be at least the same or even better with regard to ventilation and monitoring. And it also needs some issues regarding organization of your team. And as I already showed you, it not necessarily takes less time of your team. And a lot of people are also struggling with things like legal issues, security issues, and reliability of data transfer. So is it a reasonable option for all patients? Ries van der Bigelaar, who did the trial on neuromuscular diseases, looked how many patients were not able to join his study because of problems with the study setup. So here you see that patients, you see the patients excluded from his trial and the reasons why. There were, of course, patients who came in a semi-acute situation, and you will not prevent this. But there were also organizational issues, patients that could not be included because of an insufficient social network, and he also excluded children. But I think mainly the organizational issues and the social network issues, you might find other solutions for that. So adding this up, I think there will always be a proportion of patients who will stay in the hospital, so will need initiation of home mechanical ventilation in the hospital. But there will be a large proportion, we think about 80% of the people who can be initiated at home as good as in the hospital. So then digital divide. So that means that is everybody very confident with digital devices. I think that improves. You see that networks improve, and you see also that elderly people become more convinced that they can do this. What is needed? Access, uses, motivation, technical skills, and I think this will increase the coming years. Organization of your team. When we look at time spent by our ventilation nurses, and here I combined different studies, COPD and neuromuscular diseases. And you can see here that travel time is of course higher when you initiate patients at home. And in our study setup, we had at least 2 visits, also 3 was possible. And you might think of organizing this in a different way, for example, by working together with providers who can help you with, now, for example, bringing the transcutaneous monitoring back or reading it out. So, yeah, I still think that you need caregivers who educate and explain everything to the patient. So we valued the visits by our nurses very much. You can also think about organizing this differently so that it takes less time. So what should be monitored? What we did was monitoring of ventilator data and monitoring of transcutaneous gas exchange. And you can see that we can nowadays monitor a lot. This is a nice graph of Borrell showing the increase in monitoring possibilities and telemonitoring possibilities over the years. And technology seems to go a bit faster than we can do in the hospital, maybe. So we now can monitor a lot. We can monitor that every day, every minute, whatever we want, but it's quite difficult to filter out what we should monitor or how often we should monitor to also make this doable for caregivers. As I explained, when I started in the field, we initiated patients on the ICU, we moved to the respiratory ward and now to the home situation. So do we need extensive monitoring or can we use automatic modes? I think we need to learn a lot about what we should monitor. This is a study showing or comparing initiation of NIV using polysomnography versus nurse-led titration of NIV. And you actually see that the patients that had nurse-led titration of NIV did better with regard to CO2 reduction. So is it all necessary to monitor, or is it a problem that we don't know actually what to do with all the data? Recently, there has been a study published in the meantime looking at automatic modes to titrate NIV at home in patients with obesity hypoventilation. And although this worked, the patients that were automatically titrated at home had far more healthcare contacts afterwards, so that this strategy was not cost effective. And this is, of course, also not what we want. And it also stresses the importance of good education and good follow-up by educated caregivers. So what are we going to do in the future? We can monitor a lot, ventilator data, gas exchange data. We can probably monitor work of breathing, patient ventilator asynchrony. Comfort is a bit more difficult on a distance, and we might need to integrate these signals to find out what is exactly important to improve outcomes. So my take-home messages for you: home NIV setup with ventilator data and CO2 monitoring is non-inferior to in-hospital setup. It is feasible and safe, both in neuromuscular disease and COPD. However, challenges for implementation are there, both concerning techniques at home and organization. And there's an ongoing discussion about parameters that we should monitor and that can be monitored remotely to adjust the ventilator optimally, both during initiation and follow-up. So I'd like to thank you for your attention. This is our hospital during the night, and I would like to thank the patients that participated in my trial and all of my collaborators. So, and then this is the last slide for the next webinar. Thank you.
Thank you very much, Marieke, for a very interesting presentation. Really shows all the experience you gained over the last years in this field. And if you say it like that, that you started in the ICU some years ago and now you set up the patients at home, that's an incredible journey, of course. We have a number of questions here in the chat. And the first one I'd like to start with is, what happens if you knock off respiratory drive in a patient that has compensated and you remove their hypoxic drive to breathe?
A bit of a difficult question. What we see when we ventilate patients, I think it also depends a bit on disease. When speaking about COPD, when we ventilate patients for a longer period, we see most of the time that after a couple of months, people are completely relaxing and getting back to the backup frequency of the ventilator. So then the ventilator is doing the work during the night, of course, but we have to remember that these patients are not dependent on 24 hours of ventilatory support. So during daytime, when they get off their ventilator, they will just breathe normally. So they have their own respiratory mechanics to breathe with. So we think that it's feasible And it's also good for a patient to assist them during the night. So it's good that they relax a bit and that they can sleep quietly. And then during day, they will depend on their own respiratory mechanics. So we actually don't see much problems by switching off respiratory drive. I think that's also because you do intermittent non-invasive ventilation and not the whole time. So I hope this answered your question a bit, but if not, please add.
Yeah, I think the person who's online and who has posed the question, if something is again or still unclear, please let us know. A more real life or a very to the point question, how is patient comfort monitored remotely?
Yeah, that's a very good question. I think that's very difficult because you have to ask your patient whether he's comfortable or not. During the initiation phase, we have everyday contact with the patient by the telephone. So the nurse calls every morning and asks, how did you do this night? Did it feel comfortable? So she does some kind of history taking with the patient. I think that's the best. You can, of course, think about questionnaires or apps where you can monitor comfort, but still patients need to tell their story. So for the initiation period, we decided to call them every day, except for the weekends, to monitor also comfort. And it's indeed very important that it's comfortable. Of course, when you see on the ventilator readouts that the patient is not using the device, a comfort is a big issue why they're not using the device. So it should alert you to ask what is not comfortable. Is it blowing too fast? Is your nose itching, or what's wrong?
Yeah, thank you. Another question, what is your opinion about NIV at home in hypoxemic patients as interstitial lung disease?
Yeah, we don't have that. I think in hypoxemic patients, there's not much evidence that NIV is a good treatment option. Probably you should better use nasal high flow oxygen for those patients, for example. There might be patients with severe interstitial lung disease who will also develop hypercapnic respiratory failure, although I don't have experience with it. That's really a minority. And then you might have some benefit from NIV. But I think long-term NIV is shown to be beneficial in patients with chronic hypercapnic respiratory failure and not hypoxemic respiratory failure.
Yeah, thank you. I think we have an add-on comment on the first question. I assume it's the same person that makes a statement here. I've had experience of a patient stopping breathing on the ward on initiation, having to wean the settings down to start the drive working again.
Yeah, I think I now understand better what you mean, that probably you lowered the CO2 too much so that people are going under their apnea thresholds and are not breathing anymore. So that might be a problem, and of course you don't want that. It depends on the patient category. In hypercapnic COPD, we lower CO2, but it's usually climbs up during the day again, so we hardly see this. But there are neuromuscular diseases where we are tending to hyperventilate the patients, and then you have two problems. They can stop ventilating, or they feel more dyspneic when they come off the ventilator because their set point has been resetted. But when you do this carefully and you don't overventilate them, we in the clinical practice hardly see this problem.
Okay. As you mentioned patient populations, there is a question, are there patient populations that are more suitable to be set up at home than others?
A good question, a question I get a lot. Actually, for the trials, we didn't really exclude patient population. For example, patients that were alone at home were also allowed to come into the trial, and that really works. What's difficult is when you have a patient without or with bad hand function and without caregivers around them. But that's already difficult when you want to consider NIV long-term at home. So initiating NIV in an ALS patient without hand function at home, you really need caregivers that are there at home for the patient. So our nurses prefer to have caregivers around the patient, husband or children, or formal caregivers. but it's not really necessary. And patient is feeling confident, has good hand function, he can also do it alone. So that with regard to the social system, it's always something we really consider before we start to consider NIV at home. Of course, patients that come in acutely, you see that in obesity hypoventilation, we will not start them at home, we will start them at the hospital. Patients who switching or starting or invasive mechanical ventilation start at home. That's quite logical, I think. But yeah, actually, except those reasons, there are not real contraindications to start NIV at home.
Thank you very much. A question, if you have considered an outpatient department setup to reduce the travel cost.
Yeah, it's a very good suggestion. I think that's indeed a very good suggestion when you do the first day explanation and acclimatization in the outpatient clinic. Still, doing only outpatient acclimatization, the problem is that you don't have nocturnal monitoring of gas exchange, for example. And we still feel that when we do a therapy during the night, we have to check whether we really ventilate them effectively during the night. So it's a good suggestion. I think we are really going to consider that for the first day, but we still think that monitoring of gas exchange during the night should also be there. And that's the reason why we now take them in the hospital, but probably you can do the next step then at home. So that's a good suggestion to reduce the travel time indeed.
Yeah,
And it
thank you.
really also, it depends on your own facilities, how you organize this. That should be clear. That I think it's not like I'm saying that everybody should do it like we do it. It depends on your own organization.
Okay. I'm going to use the occasion to squeeze in a personal question from myself here. In the Reconsider trial, you show the cost effectiveness, but on the hospital side, you also mention travel time and travel cost. Is that cost for the patient to travel, or how should I read that?
Yeah, it's both. We both took the travel cost of the nurse and the travel cost of the patient, because for the hospital group, travel cost for the patients were higher, of course. And what we also do is that in patients that don't feel confident, patients that were in the hospital, then the nurse goes, when they are discharged from the hospital on the first day, the nurse visits the home. So it's a bit of a luxury, I think, but that's also travel time.
Yeah. There's 3-4 more questions. Is cost the primary driver for this new method of starting NIV?
Yeah, also a good question, but absolutely not. The primary driver for the first study that Anna did was the patient. Anna is one of our specialized nurses, and she's very involved with her patient group, and her own patient said to her, why should I come to the hospital? I'm already very disabled and I have my care system organized at home very well. And especially patients with progressive diseases like ALS or other neuromuscular patients, you see that very often, that they've organized their informal care very well at home. And then we take them into the hospital and everything's strange, and they have new nurses and they have to commit with all the rules in the hospital, and they don't feel relaxed at all. So she had a lot of comments saying, I don't want to come to the hospital, I want to stay at home. Isn't this possible? So that was actually the driver of the first study, and that's still the driver now, because we still, when we ask our patients, almost everybody wants to start at home.
Okay, yeah, understandable. Can it be done without transcutaneous CO2 at home is a question we have here.
Yeah, I don't know. We didn't test that. We didn't compare without or with CO2 monitoring. Maybe it's possible, but I think there are no studies showing that it's possible, and there are also no studies showing that it's not possible. So we don't know. And I think when we look at the literature, we see that especially in COPD, clinical beneficial outcomes were there when CO2 was reduced. So when you don't monitor that, you don't know that. So that's a bit of a problem. And that's also why we still stick with the CO2 monitoring to check whether we are ventilating effectively. Because if you don't ventilate effectively, you will go back to the situation in the period 1995, 2010, when all COPD studies were negative. So I think we should be careful to leave that, and it would probably be better to think about technology to help us to make that measurement more easy.
Yeah, a somewhat related question, I think, because you nicely showed the problems or the difficulties you encountered with the transcutaneous measurements. But were there other technical problems during the different studies?
Now, with the ventilator, this was really good. So we almost had no technical problems with the data retrieval from the ventilator. So that worked well. Yeah, and actually it was the transcutaneous monitor. We are using that at home already for a longer period for follow-up. So then the device is brought to the patient's home. They're using it for one night and it's returned again. So we had already experience with this monitoring at home. But it's still a difficult measurement, and we saw also during the follow-up measurements that we not always succeed in CO2 monitoring. During the initiation phase, it's even more difficult because patients have two new devices then. So it is also a bit demanding, and during the studies we had to deal with different ways of telemonitoring. So for us it would be far more feasible if there's one setup. You could connect every monitoring device you would want, every ventilator you would want. The patient doesn't have to press buttons or put on the on button or whatever, so it has to be completely without intervention of the patient, and then all the data are transferred to the hospital, preferably to our electronic patient system. So that's how we would like to see the setup now.
Okay, that's a clear message. The last question, again, a bit in the financial direction. Is there reimbursement for remote monitoring and or setup in Holland? I think that's a question which goes in many people's mind in different parts of the world.
Yeah, a very good question. And we are also in the Netherlands a bit struggling with it. There is reimbursement. However, in our opinion, that reimbursement is too low at the moment because it's reimbursed and they say, okay, we're going to reduce the hospital days, but they don't take into account that we need more time. The nurses need to drive to the patient. We need technology to buy to do this. So also in the Netherlands, there is reimbursement, but we are working on a better reimbursement so that we can keep this sustainable and also doable for our team.
Yeah, let's cross our fingers for the future that indeed the reimbursement schedules get adapted to this new way of working. So that was the last question. Thank you very much once more for this excellent talk. I think it was, I'm sure it's highly appreciated. I would also like to thank all participants for your participation here today.